just wanted to provide a bit of opportunity for any kind of burning questions or issues that people might want to have from the particular kind of presentations, and hopefully people aren't shy and might be able to have some particular kind of comments for the two of them, or they may be able to ask questions of each other. So I don't know if there was anyone who had any particular kind of question or comment for either Reinhard on his presentation or Andreas.
Really enjoyed the talks. Thank you very much. And, at HS we were having a discussion yesterday about standards and about variation, and we were having this discussion with a subcommittee of our board. And one of the questions, as we keep talking about standards, is that we hear from our board is, well, how do you ensure clinician compliance? And we tend to answer that question, it's because clinicians are making the standards. But I was wondering, Andreas, how you would see us answering that to our current board.
The question being, how do you ensure clinician compliance? Well, I'm not sure you're ever going to ensure clinician compliance. I think changing, I don't think just physician, but clinician and frankly managers' behavior is not easy, and it takes time, so I think you got to be patient. I guess I'd say you can't change behavior until you sort of say what optimal behavior is. And my observation would be that if the standard is, I think what I really love about the issue of standards, and we'll see what happens with them, is that they are developed by people that are living that, like patients and managers and providers. And if you got a bunch of thoughtful people that know what they're talking about, and on the basis of the evidence, this is what the standards should be now, I guess I'm pretty optimistic that over time, people do it. And you're not going to ensure compliance, but I think you'll see a move towards improvement. I think there's a bit of nervousness actually on the part of the Ministry of Health, actually, because some of these standards may require them or suggest that they should be funding something, right? I think the standard on wound care is going to suggest certain surfaces that maybe actually aren't currently covered by people who might be chronically ill and at home and stuff. And so, so it's not just are the docs going to comply with the standards? It's also, is the system going to do something to try and make it likely that the standards are followed?
And Reinhard, I don't know if you have any comments in terms of clinicians, that issue of, are there jurisdictions where they're quite successful in terms of uptake and compliance with government top-down kind of standard?
Well, the whole, whether you call it pay for performance, pay for quality, and you've already alluded to it, of course, then you need to be sure is what you incentivize, whether that is really in itself according to standards. The example here with the mammograms. But we see that, and maybe we hear later, I don't know whether we hear something from the UK with the quality and outcomes framework that, of course, that focuses it cannot focus on all diseases, but when you say in primary care, it's a bit like you need something like standards to then say, okay, primary care physicians, GPs, how many of your hypertensive patients are, well controlled, and the higher the percentage, the more money you can make. Of course, you need to be clear what about exceptions, if they have patients who fall outside the gutter. But and these things do happen, and I think policymakers have these ideas, and it's people like us who then say, well, it is a good idea, but do not overdo it. And especially then when and John and I talked about that last night. When you then have the problem that you only reward, let's say with the mammograms, you only reward the level. So then in areas where women are better educated or less educated, depending on the area, and where it's easier or more difficult to achieve, you reward even though the physicians didn't participate. And I said, yeah, but other countries like France also has a program like that, and they divide the pot of money. So 50% of the money is for achieving a certain level, and the other 50% is for improvement. So even if you are the worst GP in the country at the outset, and next year you have the highest improvement, then you also participate from the reward. So we need to think how we can really cleverly design such incentive systems.
Okay. And just over at the mic here.
Dave Zegan from Critical Care. Really enjoyed both your talks. My question relates to the health system's role in the social determinants of health or non-health system related determinants. I use the example of the dentistry coverage, and do we pay or cover dental care in Canada, or do we just pay for the endocarditis care that resulted from bad dental work that caused valvular? Or does the healthcare system get involved in maybe the reduction of sugar to prevent the caries that needed the dental work?
Well, I mean both. I mean, obviously, and that's what when I said we have the health system performance and we have the other determinants, and you could see that there were like the behavioral components and the non-behavioral components like pollution and so on. And of course, sugar, even I would say, is somewhere in the middle. I wouldn't even know where I put the fight against sugar, because it's not only behavioral, it's clearly also the external factors that you do something about the sugar contents in the food. So you can do this, but you still should then be concerned about dental care. And the dental care was more as an example to how you can measure these things. And of course, each country, you should then be talking to yourselves whether this is a problem. I mean, in my own country, when we had this discussion how much dental care should be covered or not, our then chancellor said, I don't want that people, when they open their mouth, you can see their social status from their mouth. And so we cover dental care to improve the chances of the lower income quintile, basically. So it's not, and this is interesting because it's not only about the health. Of course, we also know that healthy teeth are healthy otherwise, but it was also to prevent this social stigmatization. Difficult word.
So I think it's a really interesting question, and I got actually 4 quick responses. One, I don't see the dentistry as a social determinants of health thing. I think it's just kind of weird that we cover somebody to look at my tympanic membrane out of healthcare and somebody to look at my teeth as not healthcare. I just don't think that's a social determinants of health issue, to be honest. We had an interesting discussion when I was on board of Alberta Health Services, actually, about, we were putting together kind of a common, sort of a dashboard of how well are we doing. And we had that discussion, like, should we put smoking rates on the dashboard? And some people said no, because, like, it's not a health system thing, so we shouldn't. And others, and I was on that side, so I said, yeah, because I think it's important for the healthcare system to point out that these social determinants are really, really important. So I think the fact that I think people in healthcare are kind of respected people in public. And if we say social determinants of health are important, I'm not saying it's going to change the world, but I think people will listen, actually. And then the third thing, Rick Glazier, who's going to talk later this afternoon, works in a very progressive family practice group at St. Michael's Hospital, where they do things like in their primary care group, they have a lawyer who will help them take we're a very inner city hospital, so lots of really poor people. The lawyer will help them take their landlord to court because of the mold in their house, which is affecting their health. There's an accountant who will make sure that they actually get all the tax breaks back that they should be, and many of them actually aren't because they're homeless or they don't know how to fill out the tax form. And they've done a randomized trial called Chez Soi, which was a randomized trial in 6, I think one city in Edmonton, in Alberta may have even been in it. It was a randomized trial in 6 cities in this country, randomizing homeless people with mild or moderate mental health issues to either being housed or not. So the intervention was being housed. And showed, actually, as you'd expect, it didn't suddenly turn them into the most healthy cohort in the world, but it did actually decrease their use of health system resources, and it actually made them feel a hell of a lot better because they had a home. And so I do think that we in healthcare should be advocating for the importance of social determinants of health that are outside our purview, just because it's an important thing to do as members of society. But I think we in healthcare can also, just like we bring in physiotherapists and we think of that as multidisciplinary, maybe we should expand our definition of multidisciplinary to conclude tax lawyers and our lawyers and accountants.
Okay, thanks very much. And join me in thanking Dr. Busse and Andreas.